of this conference of Professor O. Somasundaram Memorial Conference 2024, organized by THIRAL-Mental Network for People, Art, Literature and Psychiatry. We have a very distinguished guest. He's an expert in art, literature and psychiatry, Dr. Femi Oyebode. He's an honorary professor, Birmingham University. He's an expert in descriptive and cognitive neuropsychiatry of delusional misidentification syndrome, an author of Symptoms of Mind textbook of Descriptive Psychopathology. His research involves phenomenology of auditory verbal hallucination and cognitive neuropsychiatry and delusional misidentification syndrome. And he has written a lot of books on art, literature, and psychiatry. And we'd like to welcome our guest, Femi Oyebode. We have an audience of around 100 people here. Most of them are students, and many are from Department of Psychology as well as from Psychiatry. So we welcome you, sir.
Thank you.
And today morning we had a session on the works of Dr. Professor O. Somasundaram.
Good.
And he is one of the pioneers in Tamil literature and psychiatry, and we are conducting the conference in memoriam of Dr. O. Somasundaram, and he had a correspondence with you in one of his literary works in Manimegalai, Tamil literature, and he spoke to you about whether the literary work involved in that particular classic literature, the depiction is about a particular person, and he wrote a letter and then you corresponded through mail regarding whether the person was suffering from schizophrenia.
Good. Great. So should I start?
Yes, sir. Yes, sir. Please.
Thank you. Thank you very much. So thank you very much to Dr. Avindan for inviting me to give this lecture. I'm very delighted and very pleased to be with you. And as we agreed, I'll speak probably for about 40 minutes, and then we'll have about 20 minutes for discussion. I should say that that Professor Somasundaram sent me a copy of his book, Tamil Literature and Psychiatry, which he published in 2013, and I received it courtesy of Dr. Karthik Bomu. So I'm very, very pleased to be able to speak to a subject that he and I have in common, that we have a common interest in. So what I aim to do is to give a kind of general introduction to the subject of the humanities in medicine and in psychiatry in particular, and then I'll go on to say what the goals of the medical humanities are in our subject, and then I'll exemplify by focusing on depression. So I'll then use a number of authors to show how the humanities can deepen our understanding, enrich our understanding of psychiatry and of how our patients, how they experience these conditions that they bring to us in our role as psychiatrists. So the what are the humanities? So if you don't mind me starting in a very basic, very way like that, what are the humanities? So the humanities in medicine, they include most famously or commonly medical ethics. I think that was the first introduction of the humanities into medical training, and of course it's always been there. Medical practice is just that we weren't trained to think about it properly. And then medical sociology, the social history of medicine, those are also areas of the medical humanities. But my own particular interest, which I share with Professor Somasundaram, is literature and the arts. So how literature and the arts, how they complement our subject. And it may be helpful just to say why it is that in the last 25 years or so, maybe 30 years or so, why the humanities have become, why they become important in medicine. And you could say that there is a crisis in the practice of medicine, not just psychiatry, in the practice of medicine. There's an extraordinary advance in the use of technology in clinical practice. And you could say that even though those advances are absolutely remarkable, you could say that they pose a problem for medicine. So if I just use a simple example of what technology is in medicine, that we now do quite often, instead of having handwritten notes, we have computerized medical records, and that has implications for the clinical encounter, for the encounter between the doctor and the patient. And it's not uncommon at all that the doctors, instead of looking at the patients, look at the screen, and they're typing as they're speaking to the patient. And most patients don't find that very, very helpful, because we are at the end human beings, and we expect to have attentive listening, to at least for the person to look at us directly and speak to us. So I just use that as a very simple example of the intrusion of technology into medicine. So the idea of the humanities, I believe, is essentially to counter this, if I might use the term, dehumanization of clinical medicine. So, so this idea of the humanities is to refresh, to remind us why we came into medicine at all, that we're there, we came as young people primarily with the intention or the interest or the wish and desire to be helpful to other human beings. So it's a very humane, very, very human subject, medicine and psychiatry in particular. So that, I think, is what why there's been a rise and rise of the medical humanities. So these my sources, and the sources in general, takes on all of what we regard as literature. So I would sometimes use memoirs, autobiographical narratives. I might use fiction. I use letters, use poetry, use the theater, drama, and use diaries. And so it essentially is everything which counts as literature. Essentially anything which uses words, and of course we are speaking animals. We are language is one of the gifts that we have, and so you can imagine how important it is to take account of language and to be properly interested in language. So to then ask the question, so what I've just done there is to say something about why it is that the medical humanities have become interesting and important. And what I want now to do is to say, what are the goals of it? What are the goals of the medical humanities? And I borrow here from an American psychiatrist, Charon, who has written quite a lot about the medical humanities, and she essentially talks about four or five purposes, goals of the medical humanities, or of literature in medicine, and of course in psychiatry. The first is that it's something to do with helping doctors to understand the life that patients live with their diseases. In other words, it wants to stop doctors just thinking that the patient is a disease or a diseased organ. It's not uncommon at all, as you all know, on medical wards, that you just think of the woman with a liver disease on bed 1, or you think of the man on bed 2 who's coming with hyperthyroidism. So we forget who these people really are, and we denote them solely by their diseases. And one of the purposes of the medical humanities is to reintroduce into the medical curriculum, and definitely into clinical practice, what the impact of these diseases are on life, on a human being's life, so that we remember that it is a person, a real person, who only happens to have a medical condition. So that's, I suppose, I think, probably the most important goal of the medical humanities. The second goal, as Charon puts it, is to help doctors to understand the power and influence of their practice on people. And that is exemplified by reading that when you read a memoir of somebody who's had cancer, for example, or motor neuron disease, or whatever condition it is, then you can then catch a glimpse of how they saw the interaction between themselves and their doctors. And that gives us an idea of the power and influence of clinical practice on the life of ordinary people, so that we can see ourselves. The way in which literature, especially theater, used to be described, that the theater holds a mirror up to human life, so that we see ourselves reflected in the theater. And the same thing, of course, is happening in a memoir or in a novel. So what Sharon is saying is that when we read somebody's account of their illness, and they give an account of the interaction with the doctors, it allows us to catch a glimpse of how the patients see us. And if we are thoughtful, reflective people, it then can help as a corrective to how we operate, to show us how we could be better doctors in the ways in which the patients would expect to find us. So that, I think, is the second way in which the medical humanities are helpful to us. The third is that because most of the transactions in clinical medicine, irrespective of specialty, is conducted in language. And of course, literature is totally embedded in language. So Sharon will say, and I totally agree with her, that when we read, that it attunes us to how language works. Or if you were to watch a film, a Bollywood film, and you see how people speak to one another, and you were to be attentive to how they speak to one another, you are refreshing and improving your own communication skills, because you're learning how people speak. Because people don't necessarily speak directly and openly. There are all sorts of ways in which people speak. And that the same skills that we have in understanding a novel or understanding poetry are the same skills that we need to understand what it is that the person is saying. So for example, in the UK culture, in the English culture, you might say to somebody, you might ask somebody, and how is that pain? And they say, well, it's not too bad. And actually that means it's terrible. So what we're saying is that you have to learn how people speak in order to work out when they're making, when they're speaking in a way in which they're understating the seriousness of what's going on, or where they're telling you something which is the opposite of what they mean. So you have to learn how to hear that, and literature. There's no better way to understand that, but from literature or from the theater or from watching films. The fourth and fifth goals of medical humanities, they're far much more complicated, and I don't particularly want to dwell on them this morning, or it's an afternoon where you are, but I should say that that the humanities as a subject area, and as an area of human scholarship, very different from the sciences and the medicines and applied science. So in the humanities, it is understood that there are multiple perspectives to a particular subject matter, and that no one's description or representation or understanding of Hamlet or of Julius Caesar, Shakespeare's Julius Caesar, he captures everything. It's impossible for one person's perspective to capture everything. In other words, that there are multiple perspectives, and that is the benefit, the real what the humanities really gifts to the human being, is that there are multiple perspectives, and therefore it allows you to understand that when you're in a clinical encounter with a patient, that even though you're a professional person, and even though you have knowledge, yours is only one of the perspectives through which their disease can be seen. So they too have a perspective on it. And there's no reason to think that your perspective is superior. It's different. And that's one of the things that the humanities teach us, that there are multiple perspectives. And it helps us to understand that even in the applied sciences, that there are multiple perspectives, so that when you are on a ward round with a surgeon who is telling you what he's going to do or what he's done with a particular patient, you have to remind yourself that even though he's talking about it as if there's only one way to do a hernia repair or to do whatever it is that he's done, you have to remember that that's just one perspective, that if you were to have other doctors in the room of in equal severity seniority, they might think that you may have waited. You might have had watchful waiting, or they might have thought that the way in which the tumor should be approached should be slightly different. So you have to, so the humanities help us to understand that there are multiple perspectives, and therefore it makes us more modest and more humble, and allows us to be able to listen with due modesty to what the patient is saying and take it seriously. And lastly, there's a way in which the literature helps us, and I'm not going to talk about that at all today, helps us to understand the nature of ethics. So if you were to read a novel or to watch a play, there's something else going on, and that is something to do with moral philosophy, something to do with the nature of ethics, of how human beings ought to behave towards one another. So novels and literature and poetry and is always speaking about that, even though they maybe not be saying it at a high level or at a very visible level. So those are the purposes and the goals of the medical humanities. What I want now to do is to move on to exemplify. So as I say, I'm going to take depression as an example, and I'll just remind us that if you are reading a book on a psychiatric text on depression, they will be talking about the fact that a depressive disorder is one in which the person has a low mood for at least a fortnight, and that the mood is pervasive and unremitting, and that there's a typical pattern to it that might be worse in the morning and gets better as the day progresses. And there might be associated features like disturbed sleep, low energy, poor concentration, reduced sexual libido, and then they may have feelings of despair and hopelessness, and they may have suicidal thinking. So that's how you will be being taught in a ward round, or in the clinic, or if you were to open a textbook. And what I want to now show is that even though that is helpful to you, but in order to get a deep understanding, an enriched understanding of our subject, literature never does any harm. Actually, it is absolutely wonderful. So if I start off with Shakespeare's Hamlet, and in Shakespeare's Hamlet, there's a little passage which is a master class in psychopathology. And he says, and this is Hamlet speaking, and he says, "'Tis not alone my inky cloak, good mother, nor customary suits of solemn black, nor windy suspiration of forced breath, no, nor the fruitful river in the eye, nor the dejected behavior of the visage, with all forms, moods, shows of grief that can denote me truly. These indeed seem, for they are actions that a man might play. But I have that within which passeth show. These but be the trappings and suits of woe." So it's a beautiful, beautiful, beautiful description of the psychopathology of. So if we turn it into ordinary language, it tells us that when you're depressed, you may choose to wear dark colors. So he talks about an inky cloak and suits of solemn black. And he talks about the fact that you might be sighing. So he talks about the windy suspiration of forced breath, and that you might be crying. So you've got the river in the eye. And he says you've got the dejected behavior of the face. And these are the forms and moods which shows of grief. So you've got in there the a medical student could do far worse than reading that, because that tells them exactly what it is like to be depressed. And Shakespeare, being Shakespeare, gives you visible features of what it is like to be depressed. So I hope that you can see straight away the beauty and wonder of literature as a basis for teaching and for definitely for understanding the nature of our subject. So I'm going to concentrate for the next few minutes on William Styron and K. Redfield Jamieson. And William Styron died in 2006. He was a famous American novelist, and his most famous novel was Sophie's Choice and the Confessions of Nat Turner. And I was born in Virginia, and obviously from the deep South. So there was slave-owning family. His family, there's a strong family history of depression. So his father suffered from depression. William Styron was educated at Duke, and Duke University is the most famous university in the South of America, and it's sometimes called the Harvard of the South. So educated at Duke and married in 1953. And of course, as you know, because I'm using him as an example, he suffered from depression, and he wrote that book, Darkness Visible, which is about 70 pages, and certainly worth reading if you're interested in these matters. So he says, this is Tyron speaking now. He says depression is a disorder of mood so mysteriously painful and elusive in the way it becomes known to the self as to verge close to being beyond description. It thus becomes and remains nearly incomprehensible to those who have not experienced it in its extreme mode. The pain of depression is quite unimaginable to those who have suffered it, who have not suffered it, and it kills in many instances because its anguish can no longer be borne. It is a positive and active anguish, a sort of psychical neuralgia, wholly unbeknown to normal life. Many of the artifacts of my house had become potential devices for my own destruction. And he goes on, that fall, as the disorder gradually took possession of my system, I began to conceive that my mind itself was like one of those outmoded small town telephone exchanges, being gradually inundated by floodwaters. One by one, the normal circuits began to drain, causing some of the functions of the body and nearly all of those of the instinct and intellect to slowly disconnect. So you can see how powerful his descriptions are. But if I might just take two or three things that he said and just highlight them properly. So one of the things he wants us to say, to help us to understand, is that the inner experience of depression is incomprehensible. It is essentially difficult to describe. So we have to have a lot of respect for that. So that this experience is not like ordinary sadness, that it is qualitatively different from ordinary sadness. And because it is so different from what a normal person experiences, in order to try to capture it, you have to use metaphors. So you can see in that last little segment, which I read to you, that he's using metaphors. He's talking about the fact that when he got to his very worst, that he started to feel as if he was being disconnected, as if it was a telephone exchange, that his mind was like a telephone exchange that was being disconnected. So that's another way to remind ourselves that these experiences are so peculiarly odd and unusual that in order to capture them, we have to use metaphors for them. The second thing that he does is to remind us that the experience is like pain. So he invents a word for it. He says it's a psychical neuralgia. And sort of those of us who are doctors know that neuralgia, if you've got sciatica, it is absolutely painful and difficult and just unbelievably disquieting. And what William Styron is doing here is trying to say to us that we have to think of the feeling that you have when you're depressed as the equivalent of a neuralgia of sciatica, and that he calls it a psychical neuralgia. And thirdly, he wants to help us to understand the nature of suicidal thinking. He wants to say that the discomfort is so intolerable that dying is easier to conceive of, so that it helps us to comprehend what it feels like, why it is that it is a drive towards killing oneself. So that's William Styron. And of course, my wish is, of course, that the audience that I'm speaking to, that you would want to go and buy him and read him. And to talk now about Kay Redfield Jamieson, who was born in 1946, she must be retired now. She's professor of psychiatry at Johns Hopkins. and she educated herself at University of California, Los Angeles. She founded the Affective Disorders Unit at Johns Hopkins, and she's a creditable. She's a clinical psychologist, but she's a creditable writer, an expert on bipolar disorders. And her books include Touched with Fire, which is manic depressive illness and the artistic temperament, her own memoir, which is called The Unquiet Mind, a memoir of moods and madness. And she got other books, Night Falls Fast, Exuberance, The Passion for Life, and Nothing Was the Same, another memoir. So I'm quoting here from K. Redfield Jemisin's Unquiet Mind. And he says, depression is awful beyond words. I would not go through an extended period again. It bleeds relationships through suspicion, lack of confidence and self-respect, the inability to enjoy life or walk or talk or think normally, the exhaustion. There's nothing good to be said about it except for it gives you the experience of how it must be to be old, to be lacking in grace, polish, coordination, to be ugly, to have no belief in the possibilities of life, the pleasures of sex, the ability to make yourself or others laugh. Depression is flat, hollow, unendurable. People cannot abide being around you. And she goes on, each day I awake deeply tired, a feeling as foreign to my natural self as being bored or indifferent to life. Those were next. Then a gray, bleak preoccupation with death, dying, decaying, that everybody was born to die, best to die now and save the pain while waiting. And then she talks a little bit about being high, about mania. So even though my subject is not manic experience today, I'll just give you a sense of her writing, what she says about what it is like to be high. When I'm high, I couldn't worry about money if I tried. What with credit cards and bank accounts, there's little beyond reach. So I bought 12 snake bite kits with a sense of urgency and importance. I bought precious stones, elegant and unnecessary furniture, 3 watches within an hour of one another in the Rolex rather than Timex class. Taste bubble to the surface, the surface in mania, and totally inappropriate siren-like clothes that she bought. So that's telling you. So you can hear an echo of what William Styron has to say. So she's saying that depression is awful beyond words, and is emphasizing, and I'm emphasizing it too on her behalf, that the experience is difficult to capture in words. And then she tells you how terrible it is and tells you how it affects your self-respect, affects your self-confidence, and it damages your relationships, and you're tired, and you feel lacking in grace and polish and coordination, and you drive other people away from you. So you can see that gives us a deeper, far much richer understanding what it is like to be depressed. And then I'm going to read you 2 suicide letters to give you a sense of what people are feeling like in the prelude to suicide. And Virginia Woolf, who was a brilliant English writer, fiction writer in her day, who suffered from recurrent depression and received DCT, and then finally killed herself. Her suicide note is an extraordinary letter. So it is very, very poignant because she writes it and leaves it on her desk when her husband isn't there, and then she walks out of the house, and the river is in Sussex, is just behind her garden, the river Ouse, and she walks through the garden gate and walks a path along her garden and goes and drowns herself in the river. So this letter, you know, that is the last willful act that she does before she kills herself. And for me, it gives the letter a special kind of feel to it. And she says, "Dearest, I feel certain I'm going mad again. I feel we cannot go through another of those terrible times, and I shan't recover this time. I begin to hear voices and I can't concentrate, so I'm doing what seems the best thing to do. You have given me the greatest possible happiness. You have been in every way all that anyone could be. I don't think two people could have been happier till this terrible disease came. I can't fight any longer. I know that I'm spoiling your life, that without me you could work, and you will, I know. You see, I can't even write this properly. I can't read. What I want to say is I owe all the happiness of my life to you. You have been extremely, entirely patient with me and incredibly good. I want to say that everybody knows it. If anybody could have saved me, it would have been you. Everything has gone from me but the certainty of your goodness. I can't go on spoiling your life any longer. I don't think two people could have been happier. V. So that letter, um, so that letter is, from a literary point of view, is a wonderful letter, beautiful paced. It's very lyrical, and it's just good if you're interested in literature. If you want to see how people use words to express how they're feeling, and how they use the words and the patterning of the words, so the lyricism of the words and the modulation of it to communicate how they're feeling. So a brilliant letter. But you can read it from a psychiatrist's point of view too. So you can see from a psychiatrist's point of view that she's had previous episodes. You can see that she's starting to have auditory hallucinations because she tells us that I begin to hear voices. She tells us that I cannot concentrate. And then you can see the pessimism that that she's not going to recover, that I shan't recover, which is not true because she's had depression in the past and she's recovered. So you can see that that pessimism is a pessimism of depression. It's not a natural pessimism, which is just to do with how you think. And then you can see the negativity and the morbidity in the writing. You know, this terrible disease, and also the idea that she's spoiling her husband's life and he's never complained, and there's no reason to believe that he feels like she's spoiling his life or anything like that. So you can read the letter as a student or as a psychiatrist for the beauty of the craft of it, but you can also read it from a psychiatrist's point of view in order to teach a medical student to itemize the symptoms of depression that is in the letter. And I'm coming gradually close to the end of my talk. So Charles Baudelaire was a French poet of the 19th century. He was a bohemian, if you want to describe. So the beginning of the kind of bohemian life in Paris. And so you could say was at the vanguard of that sort of way of life in Paris, and he had a very troubled life. And this is his suicide note. Actually, he didn't kill himself, but this is the letter, and the letter is also worth reading to you because it gives you a clue of a different kind of a suicide note. And Charles Baudelaire says, I am killing myself without any sense of sorrow. I feel none of the agitation that men call sorrow. My debts have never been a cause of sorrow. It's perfectly simple to rise above such matters. I'm killing myself because I can no longer go on living, because the weariness of falling asleep and the weariness of waking up have become unbearable to me. I'm killing myself because I believe I'm of no use to others, and because I'm a danger to myself. I'm killing myself because I believe I'm immortal and because I hope. At the time of writing these lines, I'm so lucid that I'm still copying out a few notes of Monsieur Theodore de Banville and have the necessary strength to busy myself with my manuscripts. I give and bestow all I possess to Mademoiselle Le Maire, including my little stock of furniture and my portrait, because she is the only creature who offers me solace. Can anyone blame me for wanting to repay her for the rare pleasures I've enjoyed in this horrendous world? I do not know my brother very well. He has neither lived in me nor with me. He has no need of me. My mother, who has so frequently and always unwittingly poisoned my life, has no need of money either. She has a husband. She has a human being, someone who provides her with affection and friendship. I have no one but Jean Le Maire. It's only in her that I've found rest, and I cannot bear the thought that people want to strip her of what I'm giving her on the pretext that my mind is wandering. You've heard me talking to you these last few days. So it's a completely different letter. And that is another letter worth teaching, using for teaching purposes, because you would normally think that a suicide note would not be accusatory. So you heard me read you the Virginia Woolf letter, which is a brilliant letter, very, very protective of her husband. And you've then heard Charles Baudelaire's letter, which is absolutely accusatory. So he blames his mother, and he's not very kind to his brother either. And so it's a completely, totally different letter. And I suppose the psychiatrist listening would know that this letter is much more like a letter that you might get in the context of parasuicide, if you want to use a term like that. So it's a letter which is not flowing out of what we would normally regard as a depressive disorder. That's not to say the person isn't unhappy, but it's not unhappiness that we regard as equivalent to a clinical depression. So you can see all sorts of feelings in it. You've got feelings of anger in it, and you've got distorted approaches to the world, and so on. And so that's all I want to say about Charles Baudelaire's letter. But it is worth reading. And finally, I want to cite from Professor Somasundaram's book, Kannadasan, who you will know more than I do, a Tamil poet who was born in 1927 and died in 1981, and a prolific writer, a poet as well as a lyricist for Indian films, a novelist, journalist, and philosopher. So he's another of these outstanding human beings, and this is a depiction of depression from his writing. And he says, "Suspended am I in this stupor permanent, trapped with silence as my only vent. My story is but one of turmoil and strife. It's a portrait of tears on the canvas of life, like a statue veiled, its grandeur unknown, blooming amongst sorrow. My sad life has been born, a victim of myself. I stand lone and forlorn." And again, you got that wonderful sense of what it feels like inside, captured brilliantly with words, in and eloquent and fluent in a way that reading a textbook on depression cannot give you. And that, I think, is the benefit of the humanities in our subject. So in conclusion, what I hope I've done is to draw your attention to the magnificence of language, to the absolutely extraordinary contribution of literature to our subject, and to show us, to help us to understand the life that our patients live, to give us a rich understanding what it feels like in themselves, inside themselves, when they suffer from these conditions that we try to treat and help with. And I haven't done it today, but I've drawn attention to the fact that the humanities also help us to understand how the patients perceive us and attune us. Everything about it attunes us to the absolutely wonder of language. So thank you very much for listening.
Thank you, Dr. Oyebode, for an excellent presentation. We have students here. We would like to have a discussion with the students as well. They ask certain questions.
Light. Camera முடியுங்களா?
Hello.
Hi, Professor.
Thank you.
It is an amazing presentation and really loved it. And I had an opportunity to be with Professor O. Samasundaram for nearly 10 years and travel with him in all his literary works. And I could see that the interaction between you and him was so amazing. And also, it was so heartening to see you quoting from him. I'm really glad about that. My kind of a question or a query to you is a little different in a sense. What is your understanding or your kind of views on how humanities helping advancing science rather than understand? I can completely understand that humanities helping us to understand as a person and stuff, but how, from your view, humanities helping advancing science or progressing science in the strictest sense that I can think of? I'm sorry if I'm not able to convey what I'm trying to ask, but
So if I understand you correctly, so you're asking how the humanities will help us to progress science. Is that what you've asked?
yeah, especially mental health. Yes, exactly. Yes.
So it's a difficult question to answer, but I might, if I give you an example. So if you take autoscopy, so autoscopy is a relatively rare psychiatric condition. So autoscopy, where a person, there are several forms of it. If I just talk about three forms of it. So you've got autoscopic hallucination, where you look in a mirror and you see a mirror. When you look out you see a mirror image of yourself looking back at you. And so it's like an out-of-body experience, so that you see yourself outside, but it's a mirror image of you. So that's a form of autoscopy. The second form of autoscopy is where you've got another example of yourself standing, a doppelganger of you standing next to you. And that has different characteristics to it. So it's associated with a sense of derealization and depersonalization. And the image that you've got next to you sometimes is gray, or it can be transparent, but it's generally speaking, or can be smaller. But generally speaking, it's not in natural colors, whereas the autoscopic hallucination is in natural colors. And then your third is the out-of-body experiences. I need to emphasize that we're not talking about near-death experiences. We're talking about autoscopy. So you've got usually of the material physical bodies lying prone on the bed or on the floor, and the patient will say that they can see themselves floating above their bodies. But what is strange about out-of-body experiences is that it's the image, the virtual self, contains the perceptual world, so it can see the other. It can see the real material body, which is very, very strange to imagine. So that's autoscopy. Now, of course, that experience of autoscopy is in novels, and the novels totally, they are in advance of the science. So if you read Dostoevsky's The Double, Dostoevsky himself suffered from epilepsy, and the causes of autoscopy include epilepsy. It includes strokes, and then of course it includes psychosis, schizophrenia, and so on. So to actually get a deep description of what it feels like to have autoscopy, all you have to do is read Dostoevsky. And Dostoevsky's work was written in the 19th century. And if you take a man like Guy de Maupassant, French writer, short story writer, and he had tertiary syphilis, and he has a short story which you should Google. It's called The Horla, and the Horla is spelled Horla, Horla. And in the Horla, there's a person who looks in a mirror and doesn't see his reflection. And that account is, of course, the beginnings, and that is well in advance of any understanding that us doctors and neurologists have of visual agnosia. So what I'm trying to say is that literature gives us quite often in advance of science descriptions which we now know, which we now recognize, which we now give names to. So obviously, literature can't do science, but it can do description very well. And as I've said, not only is it I can do description very well, it can do description very well in advance of our scientific understanding and description and naming of these conditions. So that's my response to you. I hope it's helpful.
Thank you, Doctor. Prof. Oyebode, my question to you as a professor. Nowadays, the teaching in psychiatry, the teaching relevant psychiatry, what happens is that the students memorize certain definitions, one, and they use this DSM-4, DSM-5 as well as ICD-11, and they have a checklist of questions for coming to a diagnosis rather than listening. The teaching in psychiatry per se here is they are more worried about the form rather than the content. They are not worried about the content. They're more focused on the form. So even when they are going to evaluate a psychopathology, they're more worried about whether it is going to be delusion or hallucination rather than listening to what exactly the patient is speaking. So here in psychiatry, we are more oriented towards biological model. So reductionistic model. We are more worried about diagnosing and then treating. So not even listening is occurring here. So my question to you is, to new students who are coming to the field of psychiatry, what is your advice or what is your what do you want to say to those students?
Yes, thank you very much. I totally agree with you that that this is a big crisis in psychiatry, and the question is how we turn things around. So if I might just start off my response by talking about what the value of descriptive psychopathology is. So if you recall, in descriptive psychopathology, Carl Jaspers is absolutely deeply interested in two ways of that humans use to understand the world. So there is how the natural sciences understand the world, and Jaspers, alongside other philosophers, Wilhelm Dilthey, who was a German philosopher and social psychologist, sociologist, the early kind of sociologists, they use the word explanation to capture the idea that the natural sciences explains the world, but that the human sciences, of which our subject is one, that the human sciences, the social sciences, the human sciences that understands the world, that if you see somebody who's crying and you ask them, why are you crying? And they say, I'm crying because my mother's just died. That as a human being, you have the term that Jaspers uses for that is empathic understanding, that you have empathic understanding, that as another human being, you just understand what it feels like to cry in the context of a mother dying. And that is not an explanation. That is an empathic understanding. But if you have a car crash and your car collides with another car and your bonnet is dented, that is Newtonian physics, and that is an explanation. The explanation is that dent is caused by the collision, and there's no empathic understanding involved at all. That's just scientific explanation. So Jaspers makes these two distinctions, and the purpose of making those distinctions, of course, is that Jaspers wants to use the term empathic understanding as well as another term which he invented, which is to say that something is ununderstandable. And then Jasper says that and we're talking now about the human sciences, the human understanding. So Jasper says that when someone's anxious or whether depressed, and they tell you what it is that's happened to them, you have empathic understanding. You know why it is that they're anxious. If they've got an exam coming, or they've got to give a public speech or something like that, another human being understands how you might come to be anxious in that context. But Jaspers wants to say that when you have a primary delusion, a delusional perception, that is not understandable. So he says that is ununderstandable. And in order to not dismiss a human being because you want to say that what they've told you is ununderstandable, Jaspers goes on to say that obviously we hope that at some point the science will help us to understand, to help us to explain why it is that that person has that delusional perception. So I just say that at the outset to set out our stall as psychiatrists. And the preoccupation with taking tick box psychiatry, as I call it, like a recipe psychiatry, as if you're cooking a meal and you're ticking boxes, which is being caused by predominantly, and I don't want to be blaming the Americans for everything, but predominantly caused by the American Psychiatric Association and the IC and the DSM system, which tells you that you can understand psychiatry just by ticking a box, which is taking us away from fully understanding psychiatry and listening properly and connecting with the patients. And you cannot do descriptive psychopathology without attentive listening. And there is a problem with de-emphasizing content. But of course, even though you de-emphasize content, you cannot understand another human being without understanding the content of what they're saying, because it's the content that puts the context in place. But I have to admit, and I agree with you, that it is a major shame that our subject has come to this, that our subject is become a tick box procedure when we are losing the humanity of the subject, which is what drove a lot of us into it. That's why we're there, that we're failing to listen to the patient. So all we can do is do what I'm doing, is to talk about it and to get the younger people to realize that it is immensely fulfilling to listen properly to another person and to have a fellow feeling with another human being and to grasp what it is at the root of their situation. And that is absolutely extraordinary, and that we just keep saying it so that people realize that it's not a waste of time or anything like that. That it's actually what makes the work that we do makes it fulfilling for us.
Any questions? Come forward. Please come forward. Yes.
That was a wonderful presentation. I have one question, Doctor. You talked about how, literature gives you a better understanding of the condition, like a greater descriptive understanding. Have you ever used it as a therapeutic tool, like ever asked your patients to use literature as, to help them to heal and get like a better understanding?
The answer to that question is no. And that's not principled or anything like that. So it doesn't mean that I don't think it works. There's a whole movement in the UK of reading for better health. And there's sorry, I forget his name. There's a consultant psychiatrist up in Liverpool who made his name out of reading clubs for patients. So I don't have any objections to it at all. Because I write myself, and a number of my patients write, and because they know, they've heard that I write, they send their writings to me. So I do have a collection of writings by patients, which is a little bit different from reading. But no question about it. I have no objections to it. I think it's absolutely, if you got that as a tool and you want to use it, I think you'll find it very, very helpful. And if you've got patients who want to write, and they want to share that writing with you, I think that's also very, very, just very good. So I don't do it, but it's not because I think it's bad or that I think you shouldn't do it, or it's just that in my career I just haven't done it, not because I think you shouldn't do it.
Therapeutic. Like you said, you use literature to help them understand the condition. Like you said, when you read patient suicidal notes and stuff, So, like I said, if they probably write about their therapeutic process, do you think that would be helpful?
As I say, I don't use it, so I can't speak from experience, But my general principle in life is to say, I read a lot. And I wouldn't read a lot if I didn't find it helpful. And there's no good reason to think that I'm different from other human beings. So I can imagine that it will be helpful, because what reading does for us is what I've shown this, today, is that what reading does for us, it gives us the access to the words to capture what we're feeling that we are yet to find words for. And secondly, it gives us my God, somebody else feels this. So it gives you a fellow feeling that, oh, I didn't know other people felt like this. So that you feel that you get a sense that you're not alone. So, and given that all of us are reading for those reasons and we get those experiences, I can't see any reason why the patients won't get it. So the answer to your question is yes. I can't imagine. There's the risk that people will always bring up, which is that it might make you worse. But I don't usually agree with those sort of ideas, because I think that reading hasn't made me worse. And I've read things which are very similar to the human experiences I've had in my life, which are not particularly pleasant experiences, but they haven't made me worse. So I lost my father as a very young man at the age of 17. I've read other writers who lost their parents when they were very young, and how painful it was. So it hasn't damaged me, if I put it like that. If anything, what it's done is help me to understand the feelings I had as a 17-year-old, and to realize that I wasn't alone, that other humans feel like that too, given the same experience. So I'm using that as a kind of example to say, I just can't see why we would think it's harmful. I just think that reading is a good in itself.
Professor?
Sir, thank you for the session. There are two questions, sir. First, if it is about mental health and heart, it was always the classics, from sixth ward, Maupassant, Bodair, Virginia Woolf. It's all named from the 19th, 20th century. And what about this last 24 years? What currently people are doing in the art literature regarding mental health? I want to know a few names or something big has happened recently. And other is why here we feel that public laughter and public expressiveness is considered somewhat hyper or things. We can't laugh wildly here. I agree. Someone who laughs aloud is treated something. They say like laughing like mad.
So I didn't hear all your questions because there was background noise. But if I
muted, sorry. Sir, it was if it is a mental health and literature, it is always about classics, right? Maupassant,
yes,
Bodair, Festival. And is there what is happening in the last 24 years? I just want to know, sir.
Yes.
Yeah.
Yes.
And about the public laughter, we don't laugh wildly. We don't laugh in the public now. We are not allowed to laugh wildly now. The expression has been shortened. So, is that a global phenomenon? So, two questions.
Yes. So I heard the first question properly. So the first question is, who are contemporary writers that might be helpful to us? And so these are just my own lists. So I'm trying to see whether I can find. I don't know whether you can see it. So that's a book which is written by psychiatrist Joanna Cannon. The book is called "Will You Read This, Please?" It's a collection of accounts by real patients paired with well-recognized but young writers giving an account of what it is like to suffer depression, psychosis, mania, obsessive-compulsive disorder, anxiety, eating disorders, and so on. So that's worth reading. That Joanna Cannon is a very well-known person. And then you have Horatio Clare, who is a writer, who is a broadcaster, who had bipolar disorder, and who wrote about it. And it's a book which is called Heavy Light, and you can look it up on Amazon. And he and I were invited by the BBC to do a radio series for them. So, and the radio series on Radio 4, which is a podcast, and it's called Is Psychiatry Working? So that's the title of the podcast. It ran into 2 series. So I think there are 13 episodes. So if you go onto BBC Sounds, you can listen to it anywhere in the world. If you go onto BBC Sounds, download Is Psychiatry Working? If you can't find it, type my name in and it will come up. So, but Horatio Clare's book is called Heavy Light. It gives a wonderful description of what has happened to him. And I've got another book. I've got all these books around me, and you can see that my study is full of these books. That's another book that's worth reading. It's called Skydiving for Beginners by a young woman called Jo McFarlane. And that is a very, very difficult to read book, because it's a book of her experience of sexual abuse by her father. Beautifully written. She's a poet. Beautifully written, very, very heartrending. But if you're interested in the inner life of what it feels like to be mistreated, then that's a book for you. And if you're then thinking of dementia, that's a book called Out of Mind, and it's by a guy called Bernlef. It's spelled Bernlef. But the book itself is called Out of Mind. It's a fictional work, but it is a properly, accurately reimagined life of somebody who's got dementia in the early phases of dementia. So there are lots and lots of books like that. But if you were looking for a source in order to capture all the people I haven't talked about today, you can have a look at that. So it's called Mind Readings. That's by me. Again, if you go onto Amazon, you'll find that, and that is an edited book which draws together a lot of literature, both classic and modern, that deals with our subject. So it looks at old age, it looks at poetry, it looks at fiction, it looks at autobiographical narratives, and so on. So you might want to have a look at that, and the references there will then alert you to what it is that you might want to look at and buy.
Thank you, Professor. Thank you so much. Thank you.
Thank you so much, Dr. Oyebode, for the enlightening presentation. I hope all the students out here listen to you and gather a lot of information about the importance of reading humanities and art literature, and to understand human experience better, to become a good psychiatrist and become a good human being. Thank you so much for accepting the invitation, and then thank you so much for coming. And
my pleasure. Thank you very, very much. Thank you.